this study was really sort of the foundational efforts to find the best marker panel that could essentially detect endometrial cancer via vaginal fluid. Vaginal fluid in this case was self-collected via a over-the-counter tampon. What we did here is we used about 29 methylated DNA markers and then went through a series of experiments over the course of about 3 years to narrow those markers down to the ones that gave the most information and had the highest sensitivity for all forms of endometrial cancer. So that is very early stage endometrial cancer, as well as later stages, and also the very important type 2 cancers, which are highly aggressive and lethal. We ultimately found that two methylated DNA markers gave a sensitivity of about 96% overall, 100% sensitivity in cancers that are grade 2 and above, and 100% sensitivity in type 2 cancers. We also found that the markers worked really well in detecting cancers that were previously found to be pre-cancer on the initial biopsy. I think one of the main challenges with the current workup for endometrial cancer is that it requires an invasive procedure. It requires typically an in-office unsedated endometrial biopsy, or in some cases, although the ACOG guidelines have just recently changed, you can use a transvaginal ultrasound to rule out the disease in patients who are experiencing abnormal uterine bleeding. There are big challenges with that. One, the endometrial biopsy is very painful. About 25% of women who experience these things find them excruciating in pain. And two, the transvaginal ultrasound really doesn't work in a diverse patient population. So patients who historically have other structural reasons for abnormal uterine bleeding, like uterine fibroids, the use of a transvaginal ultrasound actually doesn't seem to have high sensitivity in ruling out the disease for those patients. As well as for type 2 disease, there's evidence that suggests that the use of transvaginal ultrasound doesn't actually work in that form of cancer. So if you're a clinician thinking about a molecular marker or molecular markers, you're actually detecting shedding of those molecular markers versus a structural change that could be associated with endometrial cancer. That's how you can think about the utility of this, as well as you can think about this as being minimally invasive. So in this case, in the publication that we have currently, we use a self-collection option. So this would allow for patients not to actually undergo a pelvic exam. They could collect it in the office or in the privacy of their own home, and then send it back for resulting. In the ASCO abstract, we also show almost identical performance in a physician-collected swab. So we really are taking a patient-centric approach here and looking for opportunities to meet the patient where they are and how they want their sample collected. The concept of this test is to have patients who do not need to have an endometrial biopsy avoid it. So if you think about a specificity of 82 to 85%, you're looking at a false positive rate of 15%. That means 85% of the patients that don't need a biopsy would actually be saved from having to have one with this device. So if you think about it that way, every single patient should be getting an endometrial biopsy at this point. It's the only current diagnostic tool that works for all patients. And a false positive rate of 15% would essentially only have about 15% of those patients going on to needing that diagnostic procedure unnecessarily. I think about sort of the landscape of the long-held assumptions that women's pain in GYN care is something that is just normalized, and is an inevitable cost of being somebody who has a uterus, right? That you have to essentially go through these very painful procedures in order to receive adequate care. This emerging data that we have here is suggesting now that this program could provide less invasive options for patients to not have to endure that kind of pain just to be able to rule out disease. The next step for us is going to be a large clinical validation study. We know that we are dedicated to ensuring that the tests that we develop have robust and high quality clinical evidence that and enroll patients into clinical studies with diverse populations over large geographic settings so that we know that the test works for all patients and is patient-centered. That is really the next step here in order for, confidence that the test is going to work in true clinical practice and in a larger patient population beyond just these case control studies that are coming out to date right now. That study, which we refer to as Envision, is open and will enroll about across 50 sites around the United States and potentially ex-US. We are going to be enrolling over 4,200 patients who have abnormal uterine bleeding, and hopefully down the line, engaging with regulatory agencies such as FDA to receive approval for this test, which we know will help provide the confidence that the OBGYN community needs in order to adopt this.